This is Janelle Yates, Senior Editor of OBG Management. Our discussion of oral contraceptive use in women with migraine continues with the focus on how the pill can help prevent some migraines. Dr. Calhoun? How might women with migraine benefit from hormonal contraception, specifically combination oral contraceptives?
Oh, I'm glad you asked me that. I did a presentation a few years ago over in Stockholm at the International Headache Congress looking at what is the impact of just eliminating menstrual migraine. Now, we typically think when we see a patient, well, this patient has menstrual migraine, this one has chronic migraine, this one has medication overuse headache. But what we're actually seeing is quite often 2 or 3 of those combined. At a first visit, most of my menstrual migraine patients just see themselves as hormonal headache patients. But the majority of them, 70%, are also overusing acute medicines, giving them medication overuse headache, and 92% have chronic daily headache or chronic migraine. So the question I presented was, what happens if you simply eliminate the menstrual migraine? You get rid of the elephant in the living room. It's the easiest one to get rid of. I mean, we know when menstrual migraine's coming. We know what causes it. We have sample closets full of things to fix that with. Using 3 major strategies, all of which either completely eliminated the estrogen drops, like continuous hormonal contraceptives, or minimized any scheduled drops to a 10 microgram EE equivalent or less, we successfully eliminated menstrual migraine in like 81% of the population. But more importantly, when we got rid of menstrual migraine, we were 2.5 times more likely to revert them back to episodic, and about 2 times more likely to get them out of medication overuse headache.
Does the dose of estrogen make a difference in whether oral contraceptives help or hurt?
Yes and no. For most women who have migraine without aura, they could even use a 50 microgram pill. It still increases their baseline risk of stroke like it would for anyone. It increases it 4-fold. And I couldn't tell you the last time I wrote a prescription for a 50 microgram pill. But without aura, they're unlikely to have any problems with 30 or 35 microgram pills so long as they're not using a medicine such as Topamax that might increase the rate of metabolism. Topamax increases at about 38%. So if you're running a pretty high level and it's wearing off every day too soon, you could actually convert them to daily headaches. But with aura, I try to limit combined hormonal contraceptives to no more than 15 micrograms. That would be like a 15 microgram ring or a 10 microgram oral. These days I use mostly low estrogen 110 with just the 2 totally placebo days. And I also use continuous NuvaRing, having patients change it every 3 weeks, not every 4. If I have to cycle them off for bleeding, I'll use maybe a Vivel dot 0.075 for 3 or 4 days to prevent the estrogen withdrawal migraine, then go right back on active rings. But there's a variety of strategies you can use. Low C-sneak will work right out of the box, but not regular C-sneak, because the regular one allows a 20 microgram drop in EE when the patient goes from the 10 microgram, goes on to those 10 microgram pills in week 13. They go from 30 to 10.
Should there be a hormone-free interval in OC formulations? And if so, how long should it be?
Yeah, it's probably a good idea, at least theoretically, to eliminate it for everyone. But for a lot of women, that will cause some intractable breakthrough bleeding. When I see a lot of breakthrough bleeding on a continuous product, I might give them a gap of maybe 3 or 4 days of an estrogen product that limits the drop to 10 micrograms or less to get them through it. The shorter the pill-free interval, the less likely you are to have a follicle develop and then a dominant follicle emerge, which will allow for ovulation. But I still used plenty of continuous contraceptives, and particularly in women who've had an endometrial ablation, or they have a Mirena from maybe even before when they came to see me, or they've had a simple hysterectomy, but they still have estrogen withdrawal migraines on 28-day cycles. I use extended cycle treatments almost exclusively in those patients. The shorter the pill-free interval, though, the less likely you are to get into trouble with ovulation and adding their own cycle on top of what you're doing.
Should OBGYNs have their patient consult with a neurologist or headache specialist before they prescribe combination OCs?
Not necessarily. It's part of women's health. a lot of women see only their gynecologist as their primary physician, not just to deliver their baby and take care of GYN issues. But if a particular gynecologist is uncomfortable with migraine, sure, they can send that patient to a neurologist. But most neurologists are uncomfortable with women's health issues, including hormonal management of menstrual-related migraine. Coming from my background at UNC, we tried for years to get the Department of Neurology to require that all of our residents spend 2 weeks in headache before they'd finished as neurologists. We never got that approved. Some neurologists like headache, and they're quite good at dealing with it. Others have little formal training in headache management, but may be good at excluding secondary headaches such as tumors or aneurysms. It's the same with gynecologists. Some are quite good with migraine. Others are more uncomfortable with it.
So you would think that a headache specialist would be more helpful than a neurologist for a woman with migraine?
I think with migraines or cluster or any of these really bothersome headaches, you're better off going to a headache specialist. They can be found on the American Headache Society's webpage with a list by geographic area and whether they're board certified in headache. The National Headache Foundation also has a list of its membership, but you're better off going to a headache specialist or a neurologist who has a particular interest in headache.
How do you counsel patients with migraine who may be misinformed about the risks and benefits of combination oral contraceptive use?
Well, counseling is a huge part of our visit. The first visit is about an hour and a half, and most of that's counseling. We go over the medication issues in detail, whether it's their hormonal contraceptive or an anti-epileptic or whatever we're putting them on, to calm any fears or concerns they have about them, and to go over the risk of the products. We go over sleep habits in detail, medication overuse, caffeine. But obviously in my practice, I focus on hormonal issues. With all the information I present, the questions that I answer, I see very little hesitation.
In a 2010 article on menstrual migraine in OBG management, you wrote that a busy gynecology practice sees more migraineurs in a day than a neurology practice sees in a month. But most migraineurs who visit gynecology offices have a chief complaint other than headache, and most leave without having mentioned the migraine. Is this still true today? And if so, do you recommend that OBGYNs ask their patients about migraine?
Oh, I suspect that it's still true. And I appreciate that the GYN visit is much more time pressured than my visit is. I have the luxury of sitting back for an hour and a half with a new patient to talk about every aspect of their headache. But when I work in a GYN setting, as I did for over a decade, one of my partners saw 41 patients before 2 o'clock in the afternoon, and he averaged about 6 minutes with each patient. That's a different time pressure that I'm dealing with. My recommendation is on the annual physical form, simply where you're already asking whether the patient has excessively heavy bleeding or cramps. Just ask if they have headaches with their period. It's a real simple solution, maybe trying an extended cycle oral contraceptive or limiting the drop in estrogen. But if you don't look for it, you're not going to find it. And so many of these people have it. I've said many times that treating headaches is one of those really rewarding fields to do. It's probably the only good prognosis area to treat in neurology. If you get someone out of the daily headaches they've had for 11 years, their life has been changed. It's kind of like getting someone a healthy pregnancy when they've been trying for 6 years with infertility. It's a very rewarding thing to do, and I urge them to ask.
In that same OBG management article, you said, menstrual migraine is arguably the most common disabling condition encountered in women's health. These migraines are more severe, last longer, and are more resistant to treatment than those that occur at other times in the cycle. And although headache specialists are adept at diagnosing migraine and prescribing a host of anti-epileptic drugs and other migraine preventives, many of these specialists are uncomfortable manipulating the hormonal underpinnings of these super migraines. Do you believe that OBGYNs are in a unique position to help manage patients who report menstrual migraine?
Oh, they absolutely are. and I have a big grin on my face right now. I'm remembering back when I was in medical school, whenever the professor would even just say the word estrogen or progesterone, a bunch of newspapers would go up in the back page, open to the sports pages, in the whole back row of the class, and they all went into neurology. I see gynecologists, though, too, who are rightly concerned that there's a lawyer behind every door. You know, they may be hesitant to diagnose migraine, so they call it headache not otherwise specified and prescribe Fiorset, which one of my colleagues used to joke put all of his kids through college. It's the single drug most likely to cause rebound headaches or medication overuse in women. It's something that we really want to avoid patients using at all. Now, gynecologists are in a unique position to handle these women's health issues. They're my favorite audience to talk to because they've got most of the patients and all of the power and the knowledge to fix menstrual migraine. They simply have to know what we want them to do. You know, a gynecologist, told me that a neurologist once sent a migraine patient and said, put her on something that will help her headaches. He had no idea what he was supposed to put her on. If the neurologist had said, limit her drop in estrogen on an oral contraceptive to no more than 10 micrograms of ethinyl estradiol, or put her on continuous low-dose contraception, that would have been no problem. The problem is that most neurologists don't even know what to ask for when they're talking to the gynecologist, how to fix the menstrual migraine. If they knew what the goal was, the gynecologist would be great at executing the plan.
Is there anything else you would like to say about this topic?
Well, I can't think of anything really to add to it. Your questions have been excellent.
Well, thanks so much for your time, Dr. Calhoun.